So you are the one who interested to learn RA? Have a seat. Cik sabar cik sabar. Sakit tak? A few things. Follow me. A box with full of equipment. Sound. And a patient. A guidance. Anytime, every day, 24 hours. You can come and ask for us.
Yes!
I'm sure you learned something from this course. Everyone can do RA. Remember, nothing is impossible. This is the future of RA in ED.
Okay. Thank you, Dr. Rabita, for the tour of our RA suite. So a little reminder from Dr. Hidayah, do not use too much gel. Okay? All right. So as you know from the tour, we operate RA in our ED during office hours, 8 to 5. So feel free to contact any of our MO in charge of RA during office hours if you need to block a patient. Okay, so and the RA suite is situated in our yellow zone in our EDHL. Okay, next we will move on to lower limb block. This lecture will be given by Dr. Fakhzan. He is an anesthetist in Hospital Kuala Lumpur, and he is also a trainee in RA subspecialty in HKL. Dr. Fakhzan graduated from UPM and did his masters in USM. Welcome, Dr. Fakhzan.
Assalamualaikum and very good morning. So today I'm going to give you a brief lecture about lower limb block. As we all know, lower limb, we cannot run away from take consideration about the lumbar and the sacral plexus. So for the lumbar plexus, it started from L1 to the L4, whereas the sacral plexus within the L4 into until S3. So then this slide shows the innervation of the lower limb. So as we all know from the infront, most of the nerve that cover the infront is femoral, obturator, lateral femoral cutaneous, and where at the back, mostly by the sciatic nerve. Okay, so we go about the femoral nerve block. So what is the femoral nerve? Femoral nerve is the largest branch of the lumbar plexus, whereby it's from the L1, from L2, L3, and L4. Descend through the fibers of the psoas muscle, emerge underneath the inguinal ligament into the thigh. It's divided into anterior and posterior division. This is important when we want to talk about the popliteal block later. So at the femoral creases, the nerve is covered by the fascia iliaca. Femoral nerve separated from the femoral artery and vein by a portion of the psoas muscle and the ligamentum iliopectinus. It prevents spread of the local anesthetic when performing blind paravascular technique. Alright. So what are the surface anatomy? So as we know from the femoral crease, from the medial to lateral is VAN, vein followed by artery and followed by the nerve lateral to the artery. Okay. For the ultrasound guided technique, femoral nerve easily visualized using linear probe. Onset time is quick. It's almost one of the simplest block to do. How much to give? About 15 to 20 mils of LA. Alright. So this one show the how we do the femoral nerve block. Patient in supine, we put a linear probe, okay, at the femoral crease. What you want to see is, you see the femoral artery, okay, lateral to the femoral artery is a femoral nerve, right? Same, this diagram also, femoral artery and also the femoral nerve. This is the upper part of above artery and also the nerve. This is fascia lata. Below the femoral nerve is fascia iliaca. Alright. Okay. If you see this picture, this is like a Mickey Mouse sign. It means that you are too lower. You should push your probe up until you see artery, vein and the nerve. Your aim is to give your needle into here and then deploy your local anesthetic at the lower end and also the upper part. You can see from this video, this is a fascia iliaca and this is the femoral nerve. The needle came from the lateral side, okay, squeeze around the fascia iliaca and deploy the local anesthetic. Now the femoral nerve been pushed downward. So you can give about 15 to 20 ml of local anesthetic here. Alright. But you have to remember this one only used for analgesia because the local anesthetic only deploy at the upper part. If you want to use for the anesthesia, you must deploy local anesthetic. Okay, we run back the movie. This only deploy the upper part. Okay, you can withdraw back the needle and deploy in the below side to get the better coverage.
Assalamualaikum and hi everyone. In this video, we are going to show you how to perform femoral nerve block. It is the easiest and superficial block which can be performed by the beginners. It is relatively simple to perform, carries low risk of complications, and result in high success rate. The indication for femoral nerve blocks in EDs are usually for hip, femur, anterior thigh, and knee traumas, either for CMRs or pain management. So now, let's see the technique for femoral nerve block. Patient lies in the supine position. The ipsilateral lower limb is abducted 10 to 20 degrees and slightly externally rotated with the lateral side of the foot resting on the table. The aim is to block this nerve at its most accessible proximal location and optimize block distribution. The femoral nerve is at its most superficial point along its course approximately at a point just distal to the inguinal ligament, lateral to the femoral artery. Key landmark to aid identification of femoral nerve is the femoral artery. Now, place your high-frequency linear transducer on the femoral crease. To achieve optimum block, Scan the femoral artery before it branches into profunda femoris artery. Two distinct arterial patterns will be seen to distinguish these two areas, Mickey Mouse and snowman signs. Mickey Mouse signifies a more distal area along its course, whereas snowman correspond to a more proximal area along its course, which is superficial and amenable for block. Once at snowman point, focus on a triangular area lateral to femoral artery. Always ensure that probe is perpendicular to plane at all times and move in alignment throughout the distance between snowman and Mickey Mouse points. These points may just be millimeter away from each other and may even be differentiated by tilting off the transducer. Proceed to block femoral nerve by identifying a honeycomb structure at this triangular area beneath fascia iliaca, which may lie either on the iliacus muscle itself or indenting the iliacus muscle or within substance of the iliacus muscles. Needle insertion point should be about 1 cm lateral to the transducer in a lateral to medial orientation and not nearer. If needle is inserted just next to the transducer, a broader skin to needle angle trajectory will cause considerable degree of undetected reflected echoes being diverted away from the needle. Targeted needle entry area should be at apex of the triangle, which consists of fascia lata iliaca complex. We aim our needle to pass the posterior surface of femoral nerve so it subsequently becomes more superficial, creating a shallower skin to needle angle trajectory for the next needle pass anteriorly. Smaller angle of trajectory for second needle pass would enhance needle visibility. After negative aspiration of blood, LA is injected in divided aliquots covering exposed surfaces of the nerve. This block usually requires a maximum dose of 20 mL of local anesthetic. After a circumferential spread of LA around femoral nerve is obtained, our job is done. Thank you.
Okay, that's all about the femoral block. Next one, we will talk about fascia iliaca block. So what is fascia iliaca block? Classically famous with 3-in-1 block, whereby you aim to block lateral femoral cutaneous, femoral and obturator. It was said is the best option for the hip fracture primarily. Okay, so the fascia iliaca compartment is a potential space with the following limits. Anteriorly, the posterior surface of fascia iliaca cover iliacus muscle and with the medial reflection. Alright, posteriorly, anterior surface of the iliacus muscle and the psoas major muscle. Medially, vertebral column and craniomedially continuous with the space between quadratus lumborum block. Okay, for the fascia iliaca block, right, there's two ways to give, either suprainguinal or below inguinal fascia iliaca. With the current latest guideline, the suprainguinal fascia iliaca is better coverage as compared to the below inguinal fascia iliaca. So what are the coverage? You can see the fascia iliaca coverage almost all the anterior compartment of the anterior thigh. Okay, and also with the medial side of the shin, right? For the bony coverage, almost all the femur, right? Okay. So, how to do suprainguinal fascia iliaca? Right. First, you must to palpate for the ASIS, right? Patient in the supine position, you palpate the ASIS. You use a linear probe, right? And perpendicular, about 1 or 2 finger breadth lateral to the ASIS. So you aim to see what the textbook sign called the bow tie sign. This is the bow tie sign. Okay, this is the intra-oblique muscle, and this is a sartorius. Okay, so this one also the same. This is intra-oblique muscle, and this is a sartorius. Your aim is to give the local anesthetic below at the bow tie sign. Alright. Okay, you can see from this video, right? So they put here is the iliacus muscle, and here is a fascia iliaca. Here is anterior inferior iliac spine. You can see here the deep circumflex artery also. Sometimes you can notice the deep circumflex artery. So where is the needle? Needle came from the caudate. Here is the needle. Try to squeeze through to give around here, below the artery. So this one is a little bit overshoot. So the needle will retract a little bit. And try to give the locus around here. Okay. Now, the test dose was given, but however, it's not into the fascia iliaca. Alright, this is going into the muscle. So what we need to do is we need to withdraw back a needle and reintroduce your needle again. Right? So we withdraw back the needle. Okay, again, we want to give the fascia here, which is below the artery. If you can see the artery, is very good. Sometimes you cannot see the artery also. It's okay. Okay, now you can see the pop there. Yes. Now, after you give the local anesthetic, spread nicely. Okay. Sometimes people say this is a zipper. It's like a zip. When you give, it's open up. Right? How much to give? About 30 to 40 ml of your LA.
Assalamualaikum and a very good morning. In this video, we will show you how to perform fascia iliaca compartment block as an analgesic modality for hip trauma. There are two approaches for this block. The first one is infrainguinal, lateral to medial approach, and the second one is suprainguinal, caudal-capillate approach. In this video, we will show you suprainguinal approach with direct longitudinal axis technique. Patient in supine position. First, we identify anterior superior iliac spine laterally. Place an index finger immediately medial to the axis. Align a high frequency linear transducer immediately next to this finger with the caudal end of transducer just above the inguinal ligament. Alignment of this transducer should be superior medial to inferior lateral from cranial to caudal. We are using Stimuplex Ultra 360 80mm needle using in-plane approach. Here, the needle already pierced the first fascia, which is fascia lata. Now the needle is approaching fascia iliaca. This is the sonoanatomy that we need to identify. The most superficial fascia is fascia lata. Just beneath this is fascia iliaca. DCIA, deep circumflex iliac artery, lies above fascia iliaca and iliacus muscle lies below it. Two muscles you need to identify are the internal oblique and sartorius muscles at the both ends. Ilium is identified as rounded, hyperechoic rim with hypoechoic shadow below it. Some describe this as bow tie sign. Both ends of the bow tie represents the muscle. On the capillate side is internal oblique, and on the caudate side is the sartorius. So here we can see that the needle already pierced the fascia lata, which is the first fascia. Now the needle is just above the fascia iliaca. Once we feel a pop, then we are sure that we are in the fascia iliaca compartment. Once we are here, we aspirate and make sure there is no blood. If it's clear, we are going to inject our LA. We are using ropivacaine 0.2%, 20 mils of volume. We can use up to 40 mils as long as it does not exceed the toxic dose. So here we are going to inject our LA. As you can see, the LA spreads very nicely towards cranially, and if the spread more cranially, then there is possibilities it will spread to the lumbar plexus. Okay, so there is some space created by the LA, so we are going to dive in a little bit our needle and we inject some more LA into that space. So now we are going to check the spread of our LA. We put back our transducer along the inguinal ligament and we identify the femoral vessels, femoral nerves, and the fascia iliaca. So the LA, there is some LA in the compartment. So thank you.
Alright, so that's all about the fascia iliaca. Lastly, we go for the popliteal approach of the sciatic nerve block. As you all know, sciatic nerve block, you have a lot of approach. You have transgluteal, you have subgluteal, and you have the popliteal approach. Okay. This anatomy show the sciatic nerve before it reach into the popliteal fossa is divided into two, tibial nerve and also common frenulum nerve, right? So what is your aim of given the popliteal block is before it bifurcation. So roughly about above the, traditionally it's mentioned above the popliteal fossa about 10 centimeter. However, by using ultrasound, it's just above, sometimes about 2 cm or sometimes is lesser than that, right? So popliteal sciatic, what are the coverage? The coverage normally below the knee, okay, on the lateral aspect of the shin until at the toe area, almost all covered by the popliteal sciatic block. Alright, again, so you can see from here the diagram, next to the bifurcation is a bicep femoris, and then you have the nerve coverage. So you aim to give before the bifurcation. So indication, foot and ankle surgery, vascular surgery at the foot, for lower limb angioplasty, anesthesia for posterior knee surgery, right? That's the indication. So how to give? So there are a few ways of giving popliteal sciatic. Either patient can be, this one patient in prone, whereby this one patient in lateral, and some people use a technique whereby patient in supine, they support the knee with sometimes we can put what they call it, a pillow there to support your knee. Okay, so from the diagram, how to scan for the popliteal sciatic nerve. Okay, you use a linear transducer, put at the popliteal crease, alright? At the popliteal crease, what you aim to see is the artery. Okay, you can see the artery. And normally the nerve is above the artery. Okay, but this one you're not sure because this already bifurcate. What you need to do is you need to move your probe upward carefully. Okay, when you see you move the probe, you can see the other part of the nerve also appear until it merge. Okay, when it merge, this is the site for you to give your popliteal sciatic block. Alright, can we give before it merge? Can, but you have to deploy your local anesthetic two different places. Okay, this one show how to give in anterior approach. Alright, this is a probe, the needle is distant away. You can see the needle come from here. This is the popliteal sciatic, right? So you aim to give inside. Sometimes you can see the, okay, now they deploy already local anesthetic. So local anesthetic, we go around here, right? We give in the upper part first, okay? We deploy about 20 mils here, and later on we give at the lower part. So our aim is to encapsulate the local anesthetic around the sciatic nerve before the bifurcation. Okay, you go in the below, right? Then they deploy the local anesthetic there. Okay, and manage to go inside already. Then deploy the local anesthetic. So now you can see the nerve is appear to be floating by the local anesthetic. All right.
Assalamualaikum and hi everyone. In this video, we are going to show you how to perform distal lateral approach to sciatic nerve block. What are the similarities and differences between distal lateral and popliteal approach? Both these approaches have the same block coverage and similar location of block point. However, the differences are the needle insertion site and patient's position. Distal lateral approach is done in supine position, whereas popliteal approach is done in prone position. Distal lateral technique offers benefit of better needle visualization and obviate the need of patient to prone for block performance. However, in this webinar, we will be using the term popliteal approach to refer distal lateral as this term is commonly used and to avoid confusion. The indications of sciatic nerve block in ED are for below knee traumas, either for CMRs or pain management. So now, let's see the technique for popliteal approach to sciatic nerve block. Patient in the supine position. The ipsilateral leg is maximally extended at the knee with calf support. This is important because extended knee position tightens connective tissues of the hamstring muscles, making fascicle closer and compresses sciatic nerve against a background of hypoechogenic muscle, enhancing its appearance. Position a high-frequency linear probe at a point approximately 2 fingers breadth proximal and parallel to the lateral end of popliteal crease from a posterolateral approach. Align further to optimize view of the popliteal artery. The tibial branch of sciatic nerve itself can usually be seen posterolateral to the artery. Needle is inserted in plane at a point approximately equidistant from the transducer to the depth of the nerve on the screen. Viewing from a slightly posterolateral probe orientation instead of a more direct posteroanterior approach provides easier visualizations of the sciatic nerve due to early imaging of neural structures, as a more lateral approach catches the peroneal component earlier. Skin to target distance is shorter and shallower compared to a direct posterior-anterior probe orientation due to less bulkier compositions of the hamstring group of muscle laterally than centrally. Scan proximal from this location and look for the point of convergence of two sciatic branches, the tibial and common peroneal nerve. If its perineural and epineural fascia layers are not well delineated, tilting the probe towards the knee joint will usually enhance images of the nerves, making them easier to identify. Identify an injection point at bifurcations of sciatic nerve. Here, at bifurcation, the nerve shares a common perineural sheath. After the area is prepared, skin infiltration of lignocaine is injected. Advance the needle tip to pierce the perineural sheath surrounding the nerves. Always aim the needle tip at a tangent to the nerves and the safe zone of connective tissue between them, so that if you inadvertently overshoot when pushing through the tough sheath, the risk of trauma to the nerves is minimized. Entry into the sheath is signaled by feeling for tactile pops as fascial layers are pierced. Next step, assessing and recognizing appropriate spray of local anesthetic. For the maximum efficacy, the needle tip should be within the perineural sheath itself rather than between the epimysium and perineurium. This can be recognized by spread pattern. An intramuscular injection will spread up and away within the muscles. Note that when advancing, it is vital to focus on the feel of fascial pops more than trying to see the tip on the ultrasound screen. Ensure no nerve expansion, suggesting intraneural injection. Scanning off away from the needle during injection confirms that LA is spreading approximately around the main trunk and distally around both tibial and common peroneal nerve, filling up the fascial sheath. If this is seen, no needle repositioning is required and entire volume of LA can be delivered at this spot. A post-block survey scan can be performed to confirm the absence of nerve expansion and intraneural injection. We also can see here that LA has spread proximally up and beyond the level of the mid-thigh.
Okay, that's all. Thank you.
Okay, thank you, Dr. Fakhzan, for the lecture. Okay, we will have another pop quiz now. So fret not if you didn't win the first time. There's still chances for you to win as we have another pop quiz now and we have another one later as well. So we want to give equal opportunities to everyone for you to win. So if you have won, you can still join in the fun. Okay, so remember to go to www.menti.com, put in the code stated on the website on your screen and register with your full name so that we can contact you later if you have won the quiz. Okay, good luck everyone and have fun.